The following Pharma Essentia podcast is intended for informational and educational purposes only and cannot be considered as medical advice. Please speak to a healthcare professional before making any treatment decisions.
Hey, Josh.
Hey, Kay.
And hello, listeners.
Viewers.
And devoted fans. Welcome back to the MPN Pod, Stories from the Marrow.
A podcast about myeloproliferative neoplasms.
Brought to you by Pharma Essentia.
Thanks, Pharma Essentia.
Josh, you might remember, but at the beginning of this season, we changed our name.
Hold on, I didn't agree to that. I've gotten used to Josh. I don't know if I could respond to anything else, but I've always really liked Mikey. Just imagine.
Hey, Mikey.
Hey, Kay. Wait, so you got to keep your name?
I am, of course, talking about the name of the podcast, not our personal names.
Right. Duh. I don't like Mikey that much anyway.
Last season and the season before, you knew us as the PV Pod. This season, we're the MPN Pod, and we're expanding to include stories not just about PV, but also about ET, because so many of the challenges, questions, and moments along the journey overlap for people living with MPNs.
ET, as in essential thrombocythemia, which is another MPN, or myeloproliferative neoplasm, like PV.
Hey, that's right.
But that's also about the extent of my knowledge. So let's get into it with our guest. Who are we talking to today, Kay?
So I'm Tony Hunter. I'm an associate professor here at Emory University in Atlanta, Georgia. I'm part of the leukemia group here. And so I've been here for about 6 years, but in particular, I lead our MPN program here and really lead our clinical and research work in MPN diseases.
Today, we are speaking with Dr. Hunter, who's going to give us a quick crash course in essential thrombocythemia.
This is exactly what I needed. So it sounds like Dr. Hunter is something of an expert when it comes to MPNs.
My focus is pretty much purely in MPN diseases. And so I certainly am quite a focused specialist, if you will. I don't do much outside of treating MPNs. And so my clinical practice really spans the MPN spectrum, but a high number of patients with ET in my clinic, right? So we see probably a couple hundred now that are followed in my clinic specifically with ET, as well as in addition to other MPN diseases. And we see patients sort of across the spectrum with ET, right? Certainly a disease that can be highly variable from patient to patient. We have patients we treat differently. So we see sort of the full spectrum of patients.
I couldn't think of anyone better to set the essential thrombocythemia table for us.
Agreed. We are going to hear all about ET from Dr. Hunter right after this quick break.
So you're learning about myeloproliferative neoplasms on the MPN Pod, Stories from the Marrow.
Now take the next steps on your journey with Piece Together MPN. Whether you're living with essential thrombocythemia or polycythemia vera, piecetogethermpn.com can help you learn about your options, speak up, and make informed long-term decisions, from understanding test results to advocating for yourself at every appointment. Check out piecetogethermpn.com to learn more. And we're back.
Hey, thanks for making it this far.
So today we are diving in with MPN specialist Dr. Tony Hunter to get a quick 101 on essential thrombocythemia.
Also known as ET, which is the MPN we welcomed into the show this season.
Josh, any questions before we get started?
Pretty much every question you could possibly imagine, Kay. I mean, first and foremost, what is essential thrombocythemia?
That is a great place to start.
Thanks. I'm really good at starting things.
Essential thrombocythemia or essential thrombocytosis, which also gets used, or ET for short. And so, ET is one of our diseases, fits into this broader family of what we call myeloproliferative neoplasms, or MPNs.
Whew, good thing we spent the last 2 seasons learning how to pronounce that one.
But in case you need a quick refresh, Dr. Hunter says MPNs are
the classic group of sort of more indolent but cancers of the bone marrow and blood system, right? Bone marrow and blood is really one organ system, if you will. As I tell my patients, marrow is really our factory for where blood is formed. And so that's where diseases like this start from. And MPNs, ET in particular, these are diseases where really they sort of kick the bone marrow into overdrive, if you will. And so you see this increased production of some various blood cell in the case of ET, an increase in platelet count in particular. That sort of is how these patients are found and what sort of that defines the disease as far as what it looks like clinically and in the lab work that we find these patients.
So in polycythemia vera, we see an elevated blood count in all three types of blood cells.
Red blood cells, white blood cells, platelets.
While in essential thrombocythemia, it's the platelets that are the main type of cell affected. However, your other blood cell counts, like your white blood cells in particular, can also be elevated and should be monitored.
So PV and ET are both MPNs.
Alphabet soup.
For sure. But since they're both MPNs, does that mean ET is considered a cancer like PV?
Yes, very much so. Now, the classification of these diseases has changed some over the years, right? At one point, they were called myeloproliferative disorders, not myeloproliferative neoplasms. And so, I still do get a number of patients in my clinic that were just told they have a blood disease, right, or a blood disorder. And here they're in the cancer center with me. I'm telling them sometimes years into their disease about that they have a cancer, and it can be shocking. So I try to be very upfront with patients. This is a cancer. It's a lot different than a lot of the other cancers that walk into our cancer center, but it is indeed. It is a cancer of the blood and the bone marrow.
Well, I'm glad Dr. Hunter tries to be upfront and clear with his patients about the nature of their diagnosis.
Agreed. We've heard a lot of anecdotes regarding the confusion of an MPN diagnosis from patients, many of whom found out that MPNs are considered a cancer well after their first diagnostic conversation.
Okay, so ET is an MPN characterized by elevated platelet levels. What causes ET? Is it a mutation like with polycythemia vera?
Great guess, Josh.
So ET is typically driven by the presence of one of three what we call driver mutations, right? And so JAK2 is sort of our classic driver mutation. We see that about 60 to 65% of patients.
Right. The JAK2 mutation. I remember talking about that in our PV 101 episodes. So that's 60 to 65% of patients with ET. What about everybody else?
We see about 20 to 25% of patients that have a mutation in a gene called CALR or CALR, and then about 5 to 10% range with a mutation in a gene called MPL or MPL. That does leave about 10 to 15% of patients that are what we call triple negative. They don't have one of those three driver mutations, but generally have some other genetic events. And so these genetic changes, JAK2, for example, as I described to my patients, it's like this light switch that gets stuck on in the stem cells in your bone marrow and sort of kicks them into hyperdrive again until over time, sort of that one cell that develops this mutation becomes 2 and then 4 until there's millions and billions of them and they start to show up on the blood work, right, as far as this increased platelet count. So we don't, fully understand everything about sort of how the disease initiates and how it progresses over time and things like that. But we know that these sort of driver mutations are sort of a key event and sort of what ultimately drives the disease in many senses.
To summarize, the stem cells in your bone marrow go into overdrive, producing an excess of platelets.
And because it's a mutation, that means it's not genetic or inherited, right?
So it's genetic in the sense that cancer is genetic, right? It's sort of driven by these DNA mutations. When we talked about JAK2, CALR, and MPL, these driver mutations sort of drive the disease. But the vast majority of the time, it's not an inherited disease in that sense.
Got it. And how rare is ET? I know polycythemia vera is rare.
ET is certainly a disease in what we would call the rare group overall, right? Maybe not ultra rare like some hematology diseases we see, but we think, probably in the US, there's somewhere around 5,000 or 6,000 cases newly diagnosed each year, right? Now, thankfully, many patients with ET live for many years. And so the actual number of patients living with ET is quite a bit higher than that 5,000 or 6,000. But that's what we think, somewhere in that range per year. That's probably not fully accurate. We don't maybe do the greatest job of capturing that diagnosis compared to some other cancers, for example. And we also know that, in a number of our patients have probably been undiagnosed for years. So there's probably a number of patients who aren't yet diagnosed and some may who never be, especially older patients. So probably that number is a little bit artificially low, actually, from what it maybe truly is.
Just to put it in perspective, about 24 out of every 100,000 people in the United States are currently living with ET. So we've gone over some of the nuts and bolts of essential thrombocythemia. Now I'd like to talk about what it's like to live with it. What it's like to be one of those 24 out of 100,000.
That was going to be my next question. What are the symptoms of ET?
Symptomatology in ET is very unique from patient to patient, I would say, right? And we have sort of a full spectrum of patients. So we see historically up to 40 to 50% of patients with ET are incidentally diagnosed, right? Essentially asymptomatic. They have some random blood work done with their primary care doctor, or for whatever sort of random reason they had blood work done, finds this high platelet count and they get diagnosed, but really weren't symptomatic. Now, I will say that probably of that, number, that's probably a little bit overquoted, to the sense that when you really hone down with those patients, many of them probably actually do have some mild symptoms at least. But then we have, anywhere from these asymptomatic or very minimally symptomatic patients to patients with life-altering daily symptoms that really, really impacts quality of life and sort of everywhere in between that, right? And so, I sort of lump symptoms into a couple different groups of symptoms, if you will. We've got what we would maybe call more constitutional symptoms. And so these are things like night sweats, bone pains, itching, which is maybe a little bit more classic with PV, but we can see with particularly JAK2 mutated ET as well.
That all sounds really familiar. Did Dr. Hunter talk about any symptoms that were maybe more specific to ET?
And the one that we truly is the most common symptom in this disease is fatigue. I typically quote in my clinic, probably 80+% of my patients with ET report fatigue.
The fatigue associated with ET is way more than just tired. Patients living with ET report having difficulty getting through the day and needing frequent breaks for normal activities, things like that.
Fatigue is a tough symptom. There are a lot of things that factor into fatigue. That can include the disease, it can include treatments, it can include lots of other things, right? Sleep and stress and other medical problems. All these things impact what is a very multifactorial symptom, but nonetheless, fatigue is very much something that we deal with and talk about on a daily basis in my clinic with our ET patients. So fatigue is a big one. Now, beyond sort of those more kind of general or constitutional symptoms, there's sort of what I describe more as vasomotor or vascular type symptoms, right? And so this can include things like headaches, atypical chest pains, right? People get sort of sometimes transient sort of visual changes, ringing in the ear and things like that. There's also what we call erythromelalgia. And erythromelalgia is sort of one of these textbook symptoms that maybe we actually don't see that much of in clinic, but nonetheless is one that's well reported with MPNs where patients will get these episodes of sort of this burning, sometimes with kind of redness and skin changes, typically in the palms of the hands, soles of the feet, lasting anywhere from a couple minutes to hours sometimes. And that can be, common. It can be, very infrequent. And like I said, many patients don't get those sort of classic symptoms, although we do see is certainly a number as well that will get some more nondescript sort of numbness and tingling sometimes in the fingers and toes a little bit more diffusely as well.
A lot of the symptoms that Dr. Hunter is talking about, like fatigue in particular, are somewhat nonspecific and easy to brush off if you're not the one experiencing it. It's symptoms like these quote unquote invisible symptoms that get frequently dismissed. And I think it's also important to mention that some people don't experience symptoms at all. With all that combined, I'm sure it's kind of difficult to talk to your doctor about exactly what you're experiencing.
If you're living with ET, talk openly with your doctor about how you're feeling, even if the changes seem minor or vague or hard to explain. Every detail helps your care team understand the full impact of ET and guide your treatment decisions, knowing this is a chronic cancer you'll live with for the rest of your life.
Now I'm curious about the risks associated with ET.
So when I talk with my ET patients and sort of what impact is this disease going to have on your life, right? I really talk about three things. I talk about symptoms, which we just went into, and that doesn't necessarily mean the disease is worse or dangerous. It's just an annoying part of having what's a chronic disease, right? The other two are more complications that can and hopefully don't happen, right? But that includes most notably blood clotting, or what we call thrombosis, and then the risk of disease progression over time. And then I do add in as a caveat of that, we really think of these, MPNs and ET as blood clotting diseases, but we do see an increased risk of bleeding as well. And we tend to see this most commonly in patients with very high platelet counts. We call it extreme thrombocytosis. We can actually see a little bit more bleeding than blood clotting. And so although we think of them as clotting diseases, we do need to think about that bleeding risk, especially in certain patient populations as well. But the blood clots, that's tend to be historically what we've thought about most with a disease like this, right? And the number of patients that will ultimately develop this varies quite a bit from study to study, and anywhere from as low as 15, 20% to as high as 40% in some studies. So I usually say somewhere in that 25 to 30% range of patients may have some sort of blood clotting or thrombotic event during the course of their disease. That does include different types, right? So we have blood clots in the veins or venous blood clots. That includes things like deep vein thrombosis in the legs. Those can go off and kind of travel to the lungs, called a pulmonary embolus or PE. We also, though, on the other side, and sometimes perhaps slightly more common, especially in an older patient population, are arterial events. And so that's mostly things like heart attacks and strokes, or TAAs, as sort of mini strokes, if you will.
Also, I remember in some of our early discussions about PV, we talked about progression as a risk. Does that apply to ET as well?
The other big risk for patients is the risk of disease progression, right? And that can come in a few different flavors. The most common thing we see is the risk that ET progresses to myelofibrosis, again, in the same MPN family, but a more advanced MPN disease. And then we do see at a smaller rate, more like 3% or so, a risk of acute myeloid leukemia or AML. And that's a very aggressive disease when that happens, unfortunately. And we certainly see many patients who have their disease for years. I have many patients in my clinic who have had ET for decades at this point. And so many don't progress, but we do see this, right? I usually quote for ET, the risk of progression is somewhere in the 15% range, especially to myelofibrosis in particular.
ET can change slowly over time, which is why it's so important to monitor all 3 blood counts and to take a proactive approach while managing your ET.
Dr. Hunter's doing an amazing job of explaining all of this succinctly. I get so much out of these doctor episodes.
Me too. Getting educated about your disease really helps you understand important things like both long and short-term risks so that you, as the patient living with ET, can work collaboratively with your doctor to figure out an appropriate treatment plan. One thing I wanted to dig a little deeper on was the actual day-to-day experience of those living with ET. We've heard about the symptoms: fatigue, uncomfortable itching and burning sensations, headaches, amongst others. Now, what does that look like in patient lives? ET and the symptoms associated with it can be somewhat invisible at first glance, though the day-to-day impact of living with ET is very real.
Certainly, I think what's the challenge with diseases like ET and MPN disease really are chronic diseases, right? They are cancers, but they're chronic disease. It's a little bit different than, say you get breast cancer and that's terrible and you have to go through chemo and radiation and surgery, and that's a really terrible 6 months, say. But then hopefully you're done with that treatment, right? ET is a lifelong disease.
Whoa, I had never really thought of it that way before. We've talked about how MPNs don't present like your classic idea of cancers and how that often leads to people living with MPNs having their concerns diminished.
Yep, there's that phrase we hate. You have the good cancer.
Ooh. But Dr. Hunter makes a really good point. ET is chronic. As of now, you don't get to be done with treatment, and that comes with its own set of challenges.
I have a bunch of patients who come in, they see me a few times a year. They feel basically fine, right? And they go about their day and they may be on treatment or maybe some monitoring, but they go about their day. And I have a clear group of patients where ET is their life, right? Their symptoms are their life. They really struggle from a day-to-day symptom profile, profound fatigue, bone pains, night sweats, and things like that really impact quality of life. And I think what can be challenging is often it has no correlation with blood counts, right? And I talked about this a lot in my patients of like, hey, my blood counts look perfect. Why do I feel like this? And it's because these symptoms are from the disease and not always linked to exactly what those blood counts look like. All right, I have patients in my clinic who have terrible looking blood counts, right? They're all over the place, feel totally fine. And I have patients in my clinic who have perfect blood counts and feel terrible.
It's interesting to me how platelet count doesn't necessarily correlate with symptom expression. Speaking of that, how you can have a high platelet count and not experience symptoms, how do ET patients get diagnosed?
Right. Dr. Hunter alluded to that a bit earlier. Many ET diagnoses are incidental.
A large bulk of our patients with ET are diagnosed incidentally. They went to their primary care doctor for a routine visit and got blood counts checked. Or I have patients who got in a car accident, right? They got labs checked in the emergency room and they happen to find things like this. So a lot of the time it is a random, incidental, or unexpected finding of, hey, we did this lab work for another reason, but we found these high platelet counts. And that's how patients end up, usually starting on the front line with a primary care doctor. They get this and then send it to us as a hematologist to sort of work up and diagnose, for example. We do, certainly see some patients who are presenting with those complications, especially thrombotic events, right? We know, of those patients who have blood clots in the course of their disease, up to half of those occur at or preceding the diagnosis, right? So a patient comes in with a stroke, is found to have a high platelet count, and that's how they're diagnosed with their disease, right? And so I think that's less common, but we certainly see that as well. And I think what we find in my clinic, and as we look back through patients, especially patients who have a lot of their records from years before, is, really often when patients are getting sent into the hematologist, a number of them have had, abnormal blood counts, elevated platelets for years sometimes before they were actually sent into a hematologist, maybe subtly, maybe slowly increasing over time. But many of my patients probably had their disease for years before they actually made it in and were diagnosed with their disease.
So sometimes it's completely incidental. Sometimes people are coming in with complications associated with their ET, and sometimes people demonstrate a history of abnormal blood clots.
Great summary.
Thanks. I'm really good at summarizing things. Now, what kind of tests do they run to confirm it's ET?
So a few steps in really confirming or making an ET diagnosis. So usually this starts, of course, with blood counts, right? And we know that A maintained platelet count of above 450 is sort of the WHO or World Health Organization diagnostic criteria. Next, we want to take a look at other things, right? So part of that is ruling out other causes of a high platelet count, right? That includes most commonly iron deficiency. So iron deficiency is a big part of that initial workup. We also see that basically anything that causes inflammation can cause a high platelet count, right? And then another one that we see sporadically is patients who've had a spleen taken out, right? Car accident, trauma, et cetera, that filters out old blood cells, and so they'll have a high platelet count. So we want to look into all of these things that could be a different cause that's not an MPN, right? When we, don't find those things, a first step is to, as done in clinic anyway, is testing for these specific DNA mutations that we talked about, right? And really what's then the last step, I would say, to really confirming the diagnosis is doing a bone marrow biopsy, right? And certainly oftentimes we may have found one of these mutations first. So we're sort of highly thinking that this is going to be ET, and we're doing the bone marrow to confirm and evaluate baseline features, get a good sense of where their disease is at. And there are some patients too, as we mentioned, 10, 15% of patients are negative for these typical mutations. And then you have to do a bone marrow biopsy, right, to really see these bone marrow features to kind of make that diagnosis.
So we test for a high platelet count, then we rule out more common causes for a high platelet count.
Then we test for genetic mutations, followed by a bone marrow biopsy for confirmation.
You got it.
A student is only as good as his teacher. Thanks, Dr. Hunter. So we've covered what ET is, how it's diagnosed, the impact of symptoms on day-to-day life.
Next, I wanted to talk to Dr. Hunter about essential thrombocythemia treatment.
Ooh, good call. How is ET treated?
So ET treatment, I would say much like, as we talked about with symptoms, is very much an individualized approach. It really does come down to factors specific to that patient. I would say that historically, this is really driven by what we call risk stratification or determining risk. And that is mostly has to do with that risk of having a blood clot. And we have sort of a scoring system, if you will, called the IPSET thrombosis score, which helps us sort of pick within this disease who's going to be a lower risk, who's going to be a little bit higher risk for having blood clots, right? And so that depends on really three features of age, specifically over 60, the history of a prior blood clot, which is usually the strongest predictor of future blood clot, and then their mutation. We know JAK2, for example, tends to be a little bit higher, for example, risk of clotting than CALR mutations do. And so those three factors go into the scoring system, and we ultimately put people into one of four boxes: a very low, intermediate, or high-risk disease.
So treating ET really starts with understanding someone's personal risk level.
It's not a one-size-fits-all approach.
Now, how we sort of treat those different patients is the vast majority of patients with ET benefit from aspirin. Classically, this is aspirin 81 milligrams or a baby aspirin once a day. But aspirin's a mainstay for the vast majority of patients, with the caveat that some of these very low-risk patients, these tend to be young patients that have never had a blood clot, and usually with the CALR mutation, which tends to be a lower risk for blood clotting, they may not benefit from aspirin, actually. They increase their bleeding risk a little bit, but don't get much benefit. So there is a small subset of patients who maybe don't need that aspirin. Beyond that, we then need to decide, do they need some sort of what we call cytoreductive therapy? That's sort of how we phrase it, right? Treatment that lowers the blood counts, lowers that platelet count for us. And historically, sort of the metric for that is if someone's high risk, meaning that they've had a blood clot before, they are over 60 with a JAK2 mutation is who fits into that high risk criteria. That's sort of an absolute recommendation for cytoreductive therapy at that point. Some patients who are very low risk may get bleeding or very high platelet counts that cause bleeding that then require treatment, right? Even though they're not high risk for blood clotting. Likewise, there can be patients who are very symptomatic, right? Sometimes we'll initiate for symptomatic purposes and need to sort of think about therapy for that reason as well. We know that having other cardiovascular risk factors, right? High blood pressure, diabetes, cholesterol. If you're low risk, but you've got a ton of other cardiovascular risk factors, you're probably going to be higher risk. We have a little bit more to gain potentially by starting you on treatment in that case. And then what we often don't, at least historically, think about in treatment decision-making is we talked a lot about thrombotic and even bleeding risk, right? But we didn't talk about disease progression risk, right? Because historically, that has not been the indication or the rationale for treatment at ET. And I would argue that's probably okay in some patients, right? We know that, disease progression is, again, maybe 15 up to 20% of patients with things like PV and ET. And it often is the decades or more down the road, right? So if you're diagnosed at 80, maybe that's not as big of a goal, right, for patients. But I have a bunch of 30-year-old ET patients, right? And what happens 10, 15, 20 years down the road is still really impactful when you're that age group, right? And so I argue that probably need to start thinking more about, can we do things to kind of change that disease progression risk over time as well?
As ET changes over time, your treatment plans also may evolve. Your experiences, concerns, and goals also play a critical role in shaping your care. For example, a lot of people living with ET are concerned about disease progression. That's a common reason why the watch and wait approach doesn't always sit well with everybody, even though the patient themselves might be considered low risk. Concern around disease progression is also why many patients choose to pursue a more proactive approach.
Did Dr. Hunter say anything about being more proactive if waiting and watching isn't working for you?
I think being proactive is absolutely important for a good number of patients. Certainly, this again gets down to a person's individual risk, right? And that includes their risk of blood clotting and their risk of disease progression. Some of these, younger patient feels totally fine, no sort of high risk features for disease progression, no history of clotting, very low risk. Reasonable to watch and wait for some of these patients, right? But certainly there's a number we want to be more proactive about, right? We talked about as both, blood clotting and disease progression are these complications that may not, but can happen. I argue this more for disease progression for patients who are very young and have a long life ahead of them. That disease progression risk starts to be something that's more of a concern as well, where we may want to take, or at least think about on an individualized approach with sort of shared decision-making, whether we want to be more proactive for that reason as well.
Shared decision-making, one of our favorite topics. Did Dr. Hunter elaborate on that? I'd love to hear about the importance of shared decision-making in regards to ET.
I think shared decision-making is key from my standpoint. And when I see patients, especially for their first consult in my clinic, we do a full spectrum discussion of what is ET, how is it classified, what is it, what's the prognosis, what are the complications, what are my treatment options, why shouldn't we do those treatment options. And so I try to give a good overview of patients so they know what they're dealing with, what their disease is, how it is now impacting them, how it may impact on the road, and what we may do now or down the road for treatment.
I'm really glad to hear that Dr. Hunter makes it a point to thoroughly discuss ET with his patients, especially in their initial consult.
Agreed. A lot of patients have stories about how they felt their doctor didn't adequately explain their diagnosis, leading to more confusion and making it more difficult to make their own decisions about their treatment plan.
And so, I think every patient is different, again, about, how high their symptom level is and what they feel day to day. Blood counts look different from patient to patient. The risk of disease progression and thrombosis is different from patient to patient. And the patient goals are different, right? Some patients are really concerned, understandably, about that risk of disease progression over time, right? Other patients are much more concerned about that thrombosis risk and so focusing on short-term quality of life and things like that. And those are all completely reasonable things to sort of feel and want for yourself. And so, I think it's important for a physician and a patient to have a good relationship to be able to sort of discuss through all those different sort of layers that there are to making these treatment decisions to find what's right for that patient, right? Because what's right for one patient, not always going to be right for the next patient that walks in the clinic. And it's important to kind of work together to find out what's right.
So Dr. Hunter takes into account the patient's concerns and their quality of life goals when making a treatment plan. I love it.
That's what shared decision-making is all about.
But we've heard that a lot of people don't have amazing experiences like Dr. Hunter is describing, and they might want to get a second opinion. What does Dr. Hunter recommend to patients who feel that their doctor might not be a good fit for them?
Second opinions are always warranted. That's not true for just ET. That's true for anything in medicine, right? I think, a patient going through anything, especially something like a cancer diagnosis and a lifelong blood cancer like ET, you need to feel confident that your doctor is up to date, that they're giving you the right information, and you feel comfortable with your doctor too, right? Sometimes personalities just don't mesh between patients and doctors, and that's okay. That's true for any stage and anything in life, right? And so it's important to find the right doctor for you. Most of my patients, for example, are second opinions, and that doesn't always have to mean they have to leave their first doctor either, right? I have a lot of patients who, come to see me for a one-time second opinion, or even more that come to see me for a second opinion, and we share with their doctor who's closer to home, right? Maybe a not MPN specialist, but I'm 3 hours away from them, right? And their other doctor's 20 minutes. So to do that more routine monitoring, sometimes that shared approach can be a great way for academic and more community oncologists to sort of work together. So it's absolutely important, especially for a lifelong chronic disease, to feel confident, to feel comfortable with your doctor, and make sure that you found the right fit. I think most doctors in this country are fantastic doctors and have patients, interests in mind, but you're always going to be your own best advocate, right, as a patient. And so it's always to keep that in mind.
Love it.
Yeah, and I had never thought of seeking a second opinion from a specialist as a team building strategy. Sometimes getting a second opinion is about finding a specialist in your disease state or finding a specialist that lives closer to you, all of whom play an important role in your healthcare team.
Yeah, there are a lot of benefits to adding an MPN specialist to your healthcare team, right?
Many of our, community practice and private practice doctors they treat everything, from hematology to blood cancers to breast cancer and everything in between, right? And so that is hundreds of diseases. It's dozens of new treatments coming out all the time across those diseases. And so it's a hard job to keep up with all those things. Admittedly, I don't think I could do it myself. That's why I chose to become an MPN specialist instead. So I know a lot about MPNs. I can't treat breast cancer. I can't do those other things, right? But hopefully I'm good at treating MPNs. And I think that's just a different type of practice, a different frame of mind compared to sort of the average oncologist who generally is still a fantastic doctor, but has a lot smaller number of patients in their practice with MPNs, right? And I think, when you're a more general oncologist, it's easy to focus on the diseases you treat a lot, and you should, right? When you're going to get 20 breast cancer patients for every one ET patient, you're going to think a lot more about breast cancer than you are about ET. That's natural and normal, right?
That makes a lot of sense. Gosh, this has been such a great episode. I know so much more about ET now. Before we wrap this up, I'm wondering if Dr. Hunter has any advice for someone that's just been diagnosed with ET. That time right after you get a diagnosis can be so overwhelming.
I think the biggest thing as a patient is to just take an active role in your disease, right? I think, try to understand your disease, find the right doctor for you. And if you don't think you found one, found that right person. But it's important to, really be engaged in your care. I think the patients who are reading about ET are coming to me like, hey, do you know about this clinical trial? Like, I love that, right? And you should be challenging us as doctors, right, to make sure we're on top of these things. And so, but I think playing an active role in your care is key because, again, there's, if you come in and see me 3-4 times a year, that leaves a lot of days a year where you're not with me, right? And you're going to need to kind of keep track of your symptoms and what's going on and things like that. And you have your doctor there as a resource. You can reach out to us and things, but taking an active role is key. And that goes a long way too with just health over time, right? We know that, probably one of the best ways to combat MPN-related fatigue is to stay active, right? To live a healthy lifestyle, be active, to exercise. And that goes a long way as well for that disease, risk as far as thrombosis, right? We know a lot of these, especially heart attacks and strokes, being active, being healthy, these things go a long way on preventing those sort of risks. They keep you a healthier patient. They make you a better candidate for, God forbid, we progress and we have myelofibrosis down the road and we want to think about things like bone marrow transplant. The healthier you are, the more, you're a candidate for things like that in clinical trials. So taking an active role in your health and understanding your disease are key.
Taking an active role in your health is always good advice. And it reminds me of something we haven't really talked about yet, advocating for yourself in regards to ET. Self-advocacy is so important.
Well, lucky for you, next time we are going to be speaking with a person living with ET, and we are really going to get into what it looks like to advocate for yourself throughout an ET diagnosis.
Wait, but I want to learn more about that now.
We have to wrap up this show, Josh. We'll leave it for another episode.
I'm terrible at ending things.
We got this.
Thanks for joining us on the show, Dr. Hunter.
And as always, thank you to everybody tuning in. We know people living with essential thrombocythemia are going through so much on a physical and an emotional level, and we hope that this episode was helpful in overviewing everything for ET.
Definitely. And we're so excited to get you more information to assist you on your MPN journey in the coming episodes. We'll see you next time on the MPN Pod, Stories from the Marrow,
a podcast about myeloproliferative neoplasms.
See ya.
Bye. The MPN Pod, Stories from the Marrow, is produced by Believe Limited and Bloodstream Media and made possible thanks to our sponsor, Pharma Essentia. The MPN Pod is hosted by me, Kay Vermeil, and my co-host, Josh Bragg. If you like the show, please share it with anyone for whom it might make a difference, and leave us a rating on Apple Podcasts or Spotify. We'll see you next time.